From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Welcome to this JAMA Network podcast. I'm Mary McDermott, Deputy Editor of JAMA, and today I'm here with Dr. Jeffrey Katz, who is Professor of Medicine and Orthopedic Surgery at the Brigham and Women's Hospital and Harvard Medical School, and we'll be talking about Dr. Katz's review on spinal stenosis. Dr. Katz, welcome to this JAMA Network podcast.
I'm delighted to be here. Thanks, Dr. McDermott.
Thank you. So I wonder if we could begin the podcast by having you talk a little bit about the prevalence of spinal stenosis and also risk factors for spinal stenosis.
Sure. This is one of the really common problems that are seen in primary care and in musculoskeletal practices. It's estimated that worldwide there are over 100 million people who have spinal stenosis, and there are over 350,000 in the US who have surgery for this condition. So this is a common condition, and the principal risk factor is age. This is a problem that we begin to see in people in their 50s and 60s, and it becomes particularly common in the 7th, 8th, and 9th decade. Individuals who have a spondylolisthesis from an early age, this is more common in women, are at higher risk. And there are some anatomic risk factors, such as a sagittal orientation of the facet joints, that also are associated with a higher risk of stenosis.
And for our listeners, what is spondylolisthesis and is it acquired?
Yes, spondylolisthesis is an abnormality in the anatomic position of the vertebrae, whereby one vertebrae is slipped forward with respect to the adjacent vertebrae. A very typical scenario is at L4-5, the L4 vertebrae is slipped forward by usually just half a centimeter or so above the L5 vertebrae. And this can occur in younger individuals as a result of injury, and then it is what's called a spondylolysis, where the slip occurs because there's actually been a break in the integrity of the vertebral segment. But it's much more often, and especially in this age group with spinal stenosis, is acquired in older age as a result of disc degeneration and loss of disc height, which allows some instability in the segment and the vertebra to slip forward.
And how do patients with spinal stenosis typically present?
The most striking feature of spinal stenosis is that it's individuals who have back pain that is much better and sometimes even abrogated completely when they sit and worse when they stand or walk. It's also typical that the pain is localized not just to the lumbosacral spine, but almost always also in the buttocks, and it very often radiates into either the posterior thigh or lateral thigh or anterior thigh. Commonly, although certainly not always, patients have some degree of numbness and tingling. And these symptoms are typically in the back and thigh, but can radiate into the lower leg and foot as well.
And is it commonly bilateral?
It is commonly bilateral. Most patients will, describe one side as being a little more severe than the other, and it's not rare at all for it to just be unilateral. And that is likely attributed to the fact that the process of narrowing in the spinal canal and in the foramina, where the nerves exit the canal to get out to the legs, isn't necessarily symmetric, so it can be worse on the right than the left, or vice versa.
And if a primary care physician suspects spinal stenosis, what should they do? Should they image? And if so, what imaging test?
This, again, is a very common problem in primary care, and the diagnosis can be made clinically without MRI or CT cross-sectional imaging at first. I think in a patient who hasn't had a prior lumbar spine X-ray, it's a good idea in somebody who presents with back pain, some radiation into the buttocks and legs, changes with position as I described. I think it's a good idea to do a plain film, including a lateral view and an AP view, in order to appreciate whether there's a spondylolisthesis as well, and in order to rule out a fracture or other problem that would lead you down a different pathway diagnostically. But I think that treatment can begin without really confirming the diagnosis structurally, which would require an MRI or a CT scan in persons who can't undergo MRI.
And what is first-line therapy? Again, considering treatment by a generalist.
I think one of the most effective, although very simple things that clinicians can do is to almost report back to the patient the symptoms that they describe and suggest to them how that might influence the activities that they do. So patients will very often provide this really striking story of symptoms that are better when sitting, worse when standing, worse when walking. And so obvious as that is to patients, it's not necessarily clear that, for example, exercising on a stationary bicycle would be much more tolerable than walking or exercising on a treadmill. So I think just helping patients understand the mechanics, the improvement in spinal flexion is helpful. Patients also often come in concerned that they're beginning to stoop forward, and sort of easing patients' concern about that, saying you're stooping forward because that's how you're able to experience less pain. It's not such a problem. I think that's actually very helpful to patients as well. It's a painful condition, and so I think patients will typically have already reached for example, over-the-counter nonsteroidal anti-inflammatory medications, but they're often very helpful. And in patients who are able to tolerate a prescription or OTC nonsteroidal medications, I think that's a very sensible thing to do as well. So those are good places to start.
So what do you do initially with the patient with spinal stenosis?
Pretty much what I just described. Sometimes because I'm a rheumatologist and have to some extent a referral practice, people have been through some of this, but I see people very often presenting just as I described. Really, I'm the first person that they speak to about this, back or buttock problem that they're having. And so I do just as I described. I set aside some time to help them understand the relationship between symptoms and posture and activities. I assess whether they are good candidates for being able to use a nonsteroidal medication. They very often would like to be active, and the reason they're coming in is because they've had to slow down. And so I'll talk about things like using an exercycle, like continuing to walk, but taking small breaks in between. One of the striking features of this history is that patients who develop these claudicatory symptoms when they're walking often can relieve them with sitting almost immediately and be good to go again in even 2 minutes. And so encouraging patients to take advantage of that.
And do you typically refer to physical therapy as part of that?
I often do. I think that in somebody who's very active, who's maintained good muscle tone, who's fairly flexible, I don't know that a PT is all that useful for those individuals. More typically, people are less active and they've been slowed down by this problem, and they benefit a great deal from physical therapy. And the therapists will typically address strengthening of the core muscles. They'll reinforce this idea of having the patient take advantage of the mechanics and do activities in flexion to the extent that they're possible. They'll work with them on some neuromuscular exercises that really just implies that, will have them strengthen doing activities that are functional that they would do in their everyday lives. So I think for many patients, it is very helpful.
And if the generalist prescribes the things that you've mentioned and the patient returns and they're not substantially better, at what point do you refer? And do you typically refer then to a surgeon or do you refer for an epidural first? Perhaps you could talk a little bit about the efficacy of an epidural.
Sure. So exactly as you suggest, if the person has given a go at physical therapy, has tried nonsteroidals, tried to modify their activities, and they're not getting any better, typically at that point, 8 to 12 weeks have passed. And I will talk to patients at that point about potential next steps if they're interested. The literature on epidural steroid injections is rich and it's very interesting. There really are two themes. One is that in some very well conducted, well controlled trials, it's clear that epidural injections are not more effective than saline injections into the epidural space after a period of, say, 6+ weeks. And in the first several weeks, epidural injections do seem to offer an advantage over saline injections. And so they are efficacious for a very brief period of time, just 3 weeks or so. After that, no better than placebo. Now, that said, we don't prescribe placebo, but there is a very strong placebo effect. Both the epidural injections and the saline injections are associated with rather marked improvements. And so, as a somewhat, holistic thinking clinician, I don't particularly concern myself so much for whether the patient's that the whole effect the patient is getting is a part placebo, part steroid, mostly placebo, mostly steroid. What I think the patients are concerned about, and I join them here, is that these injections tend to be helpful. And so I do offer them to patients, knowing that some of the effect is placebo, as we know from the saline control trials. I think it's very important for patients to recognize, however, that all injections carry the risk of infection and that epidural injections, because we're going into a space where the neural structures run, are also vulnerable to bleeding complications. These are very rare. They occur on the order of 1 in 1,000 times a neurologic injury because of a bleed or a deep infection, but they're serious problems. And so I try to make sure patients are aware of that. Some patients have pretty strong preferences about not wishing to undertake those risks or not wishing to have injections of any sort. And I certainly respect that. The benefit is transient. And so I think it's a very reasonable position for patients to decline. And I think it's equally reasonable for patients to assume the risk and give it a try.
When do you refer to surgery?
It's interesting if I could just contrast, in patients who have, for example, a herniated disc, and I see a lot of those as a clinician, I spend a lot of time holding patients back in a sense and trying a second epidural and trying, because the natural history is really on their side. If we can wait it out, we can usually avoid surgery for a disc protrusion. Spinal stenosis is a somewhat different story. The natural history is one that's characterized by rather infrequent spontaneous improvements and infrequent dramatic worsening. And so, on the one hand, it's safe for patients to not have surgery, to delay surgery. We can talk in a moment about sort of red flags where you'd want to, have surgery considered urgently, but those are unusual. But on the other hand, the natural history is often such that patients will continue to struggle with this problem. And these are older people, they have much higher risks of surgery than perhaps, their counterparts with disc protrusions who are typically 30 years younger. So it's a discussion that often plays out over more than one visit. But in somebody who has not responded to an epidural, perhaps a second epidural, whose symptoms continue to bother them and who are really starting to miss activities that they value a great deal, I like to introduce them to surgeons and also to the idea of surgery because it's an effective operation.
What are those red flags for surgery, that is?
Yeah, so there are two issues, I guess I would say. One is, is the diagnosis right? Is it spinal stenosis? Or, does the patient have an infection or cancer or whatever? And so that set of issues is adjudicated by the MRI, which we've gotten at this point. So in somebody who does have established spinal stenosis, an unusual problem, but one that we're alert to, is whether they develop a cauda equina syndrome. So, cauda equina syndrome refers to compression of the sacral roots that subserve the bladder and the bowel and can be accompanied by urinary retention, typically, occasionally by bowel incontinence and by anesthesia in the perianal area, but what patients will identify first will be urinary retention. So this is unusual, and in people who might be taking medications that can cause urinary retention, there is a differential, but that complaint should be taken very seriously, worked up quickly, and if it is indeed appears that it might be related to spinal stenosis, I move very quickly to have them seen by a surgeon because bladder complications from cauda equina syndrome aren't always reversible and, of course, are very disabling.
And then can you talk about the different surgical methods? And the review talks about surgery with and without fusion. I wondered if you could discuss that issue briefly for us, please.
Yes, it's an important and complex issue. There are several trials now that establish quite clearly, I think, that in individuals who have lumbar spinal stenosis and do not have a spondylolisthesis or a concomitant degenerative scoliosis, meaning that their lumbar spine alignment is normal, the surgery is basically a decompressive surgery, typically a laminectomy, meaning that the surgeon removes some of the lamina in the posterior part of the spine so that they can get access to the structures that are causing compression: overgrown or hypertrophied facet joint, hypertrophied ligamentum flavum, which is posterior to the cauda, some disc protrusion. Those can all be accessed through a laminectomy. In fact, over the last couple of decades, surgeons have increasingly used more limited laminectomies, even a hemilaminectomy, where they go in just on one side where there appears to be worse compression. That's a surgery that, like all surgeries, poses some risks of infection and but where the recovery tends to be fairly quick. People often spend a night in the hospital, but seldom more than a night, and are back on their feet really within days, and their recovery process is typically over within a couple of weeks. However, if patients do have a concomitant spondylolisthesis, which we described at the outset, a displacement of one vertebrae with respect to the other, usually by several millimeters to a centimeter, in those instances, there's concern that if you do a laminectomy and remove more bone, instability can increase. And so, in those instances, surgeons will typically recommend doing a fusion, meaning fusing two adjacent vertebrae, sometimes three, together. And the techniques to do that are to lay down some bone graft posteriorly along the segments that are going to be fused, and also typically to use a instrumentation construct to assist and to hasten the fusion. What's typically done are to use pedicle screws that screw into the pedicles and then the vertebral bodies, and to connect those screws with rods or plates. So that even the sound of it sounds like a lot of surgery, and it is. So that makes it a much more complicated surgery with considerably higher rates of infection. The anesthesia is longer, so there are higher rates of medical complications. And the literature on whether and when fusion is indicated, is necessary, is evolving. There are some trials that suggest in a fairly modest degree of spondylolisthesis, a decompression alone without a fusion can be as effective as a decompression with fusion, but with fewer complications. There's a couple of trials that address that. The trials are mixed. At least one well-done trial favors fusions. So I think what I suggest to patients and what I sort of help them with in my referrals is to refer to surgeons who are abreast of this literature, who are critical thinkers, and who think very carefully about when fusion really is necessary and when it's not, because this is an evolving area.
Thanks very much for that clear explanation and for all of the really helpful information about the diagnosis and treatment of spinal stenosis. Dr. Katz, are there any final comments you would like to add?
I would perhaps emphasize, imagining that many of our listeners are clinicians themselves, that this distinction that I created between the generally favorable prognosis of back pain in general and of disc protrusions, which has led us to try to reduce the amount of disc surgery, that should not dictate necessarily our thinking about lumbar spinal stenosis. We have older people, often, who've just retired, who have a lot of activities that they'd like to do in the decade or so in front of them when they really are going to be healthy enough to do them. And this problem can really slow them down to a halt. And so I think that, as I said earlier, whereas I hold back surgery in younger patients with disc protrusions, I make introductions to surgery a lot more readily here, because I think that for some of these patients, it can just make an enormous difference in this kind of last active chapter of their lives.
Thanks very much, Dr. Katz, for the helpful information about spinal stenosis. Thanks for listening. This podcast was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Jesse McQuarters, Shelley Steffens, Lisa Harden, Audrey Foreman, and Mary Lynn Ferkaluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.